Hello everyone, my name is Alicia Sweeney and welcome to my presentation on analgesics and their implications for rehabilitation in skilled nursing facilities. As a skilled nursing facility clinician myself, I was not surprised when I discovered that the number one most common drug administered in skilled nursing facilities is analgesics. Whether our patients are coming into a skilled nursing facility with a cardiopulmonary diagnosis, a total hip replacement, or even if they're coming there for end of life or palliative care, these patients are most likely taking analgesics for pain relief. Pain can be defined as acute, persistent, and chronic. Pain can be divided by body region, such as upper extremity or lower extremity. Pain can be related to physiological processes such as nociceptive pain, inflammatory pain, neurogenic pain, and maladaptive pain. Now, nociceptive pain is pain that occurs as a result of physical damage to the body or even potential damage to the body. There are three types of nociceptive pain. There's radicular pain, which can be seen in radiculopathy. There's somatic pain, which activates the receptors in the tissues, often stimulated by movement, such as headaches, cuts, sore muscles, broken bones, things of that nature. Then there's visceral pain, which is internal organ tissue damage. This can be seen in patients with stroke or heart attack. There's inflammatory pain, which is the increased sensitivity to the body's inflammatory response associated with tissue damage. This typically serves as a reminder of a recent injury and is not so much of as an alarm. A condition that would display inflammatory pain would be rheumatoid arthritis. Neurogenic pain is due to a dysfunction of the peripheral or central nervous system in the absence of a nociceptor stimulation, meaning that there is no apparent cause of pain, such as looking at your arm and knowing that it hurts because there's a cut there. Some types of neurogenic pain can include nerve damage, cancer, multiple sclerosis, and even diabetes. Medications are typically staged. Physicians attempt to start the medication that is least likely to cause adverse effects to those who have a greater risk of these effects. Typically, medications are given in the order presented in the chart, with acetaminophenes being the first, then progressing to strong opiates depending on the severity of the pain. Included in the right, you will see kind of a step-by-step progression of the administration of medications, starting with step 1 being mild pain, all the way up through step 3 with severe pain. For simplicity and condensation purposes of this presentation, I'm only going to cover the most common analgesics seen in skilled nursing facilities, but it's still important that we are aware of all the implications that occur with all types of analgesics. First, we'll start with acetaminophen. Some side effects of acetaminophen include severe liver toxicity, renal insufficiency or decreased urine output, rash or blood dyscrasia, which is the abnormal material in blood. This can be tested with a white blood cell count blood test. And what does this mean for rehab clinicians in skilled nursing facilities? Well, we must educate patients on the use of alcohol while taking acetaminophen. This medication already imposes a risk for severe liver toxicity, and adding alcohol to the liver does not make for a good combination. We should monitor urine output with our patients, make sure that they're using the bathroom regularly, and report if they are not to nursing so that they can monitor this as well. And we as rehab clinicians can monitor the skin. We can do skin checks and assessments to make sure that no rashes are appearing or any side effects. Next, we'll look at NSAIDs. This is your common Advil, as we all refer to when we have a headache. Some side effects of taking Advil or NSAIDs include prolonged bleeding time, increased bleeding and frequent bruising, gastric complications, hepatic and renal dysfunctions, drowsiness, dizziness, headache, sweating, and depression. What we must look out for in the skilled nursing facility setting is be alert for symptoms of stomach ulcers. We also must use caution and guard patients during transfers. Now, I was very surprised to hear this because I don't necessarily think that a person taking Advil or an NSAID would have a side effect of drowsiness or dizziness. But as you can see, we must keep this in mind as well. We also must be aware of the signs of depression and report them. A lot of our patients confide in us and tell us things, and we must, look and see if they are clinically depressed and get those findings to nursing or a physician as soon as possible. Next, we'll take a look at adjuvants. These can be antidepressants or anticonvulsants. Some of the side effects of antidepressants include urinary retention and constipation, sedation, orthostatic hypotension, and tachyarrhythmias. Side effects of anticonvulsants include sedation, dizziness, confusion, nausea, vomiting, constipation, and even bone marrow suppression. Things we need to be aware of as rehab clinicians include using caution when transferring patients. We must guard them due to their risk of orthostatic hypotension. We don't want them to get up too fast and get dizzy and pass out, or with the increased risk of sedation and dizziness with anticonvulsion medications, we also need to be aware and on guard when transferring our patients. We should advise that the patients change positions slowly and monitor their blood pressure. We should also monitor their heart rate, as antidepressants can cause tachyarrhythmias. There's an increased risk of angioedema if used in combination with ACE inhibitor or antidiabetics, so we must assess the patient and look for any underlying skin inflammation. Most commonly, this is found in the lips and the face. Last but not least, we'll take a look at opioids. These are the strongest analgesics and are considered narcotics. Some side effects of opioids include sedation, confusion, restlessness, agitation, headache, dizziness, hypotension, bradycardia, urinary retention, nausea and vomiting, respiratory depression, and they are very addictive, meaning that our patients can develop a very high tolerance for these medications and become dependent on them. What this means for us in rehab, we must use caution when transferring these patients. We must monitor their heart rate frequently. We must monitor their O2 saturation as well, especially patients in skilled nursing facilities. A lot of them have pulmonary dysfunctions, so we also need to be mindful of that. And we need to assess for symptoms of dependence and communicate these concerns with nursing or physicians. Again, kind of the same as looking for signs of depression. We can not necessarily treat these patients because it's not in our scope of practice for these things, but we most certainly can communicate all of our findings to the appropriate people. Taking a further look into the use of analgesics and kind of wrapping up and concluding, skilled nursing facilities are primarily comprised of patients with comorbidities such as cardiovascular, pulmonary, renal, and hepatic dysfunctions. So we must be able to look at the pain medications and analgesics that they're taking and help decide if those medications are the best fit for the patient. Most of these patients suffer from chronic pain and they rely heavily on the use of analgesics for pain relief. We must have knowledge of medication side effects and interactions. This is imperative in the skilled nursing facility as most of our population consists of elderly adults. I do want to point out that opioid dependence is overlooked. Maybe overlooked is not such a great word to use, but it's not so much of a concern when treating patients who are terminally ill. Thank you for